This morning I want to go over with you a minimally invasive surgery performed to correct the patient who had previously had a Hemi implant done for hallux rigidus. Let me just show you the x-rays first. This is how she presented with us. She had a Hemi implant done some years ago. When it was first done, she had a complete relief in pain. This was done by another provider. But you can see now it's kind of closing up on her. What he did was he did a silver bunionectomy and put the implant in the hallux. And this gave her some years of relief, but it kind of started gradually becoming painful for her. And when she presented with us, you can see how her foot now was beginning to kind of close back down here. She wasn't getting any movement in the first metatarsophalangeal joint, so obviously she was beginning to have pain again. Let me show you her foot now. We're about two and a half months afterwards now. What we did, we corrected this with minimally invasive surgery without having to remove the implant, and I'll show you how we did that. Let me just tell you why the implant failed. If you look at her foot, she has a rigid rear foot and a flexible forefoot. But her first ray, she has more supination in range of motion. She has a high CERN perm level. So in that first surgery where they did the surgery on her, the first metatarsal needed to be plantar flexed in order to prevent this from becoming a problem for her. So looking back at her x-rays, and we're challenged with this, what to do with this. I didn't, one way to correct this would be to redo this and put a double stem implant or diffuse this. But I want to try to tackle this with minimally invasive surgery without having to take out the implant. So what I proposed that we do was do an osteotomy, which I call the PRIV procedure. That stands for the Peacock Revered Niche and Bosch procedure, in which we make a cut in the distal diaphyseal bone, move the metatarsal head over and plantar flex as well, then K-wire it with one K-wire from the dorsal aspect like this. What I just proposed to do with this was to keep the stem in place and take a wedge osteotomy distally, go underneath the stem, and sort of like a squared angle to pull the hallux up to give us greater range of motion, leaving the implant in place. So that's what we actually did with her. Let me show you her x-rays today. This is her x-rays. This is the AP today. Here's the osteotomy we did 8 weeks ago. You see some secondary bone healing pretty good. What we did with our cut here, we went distal to the stem and then proximal underneath the stem, so it pulled the toe up. You can even see a dramatic difference now in the actual lateral x-ray. You see how much now our toe is up. I want you to look at this really closely here. See how we were able to maintain the metatarsal plantar flex. You see it stepping down. When we transferred it over, you can see it's actually stepping down here. We K-wired it in this position here. And I'm going to show you that right now on the computer how we did that. Okay, this is our image on the computer we did during the surgery. You can see when we did our osteotomy, we actually transpositioned it laterally and plantar flexed it, and then K-wired it in this position here. You can see the plantar flex attitude we got here. And we did this under C-arm so we get a good K-wire fixation here. And this is sort of how that looks. Look how much range of motion, even in the OR table, we've got there. And I'm going to show you the range of motion today too. A tremendous improvement in her pain, and without having to take the implant out and do a big surgery on the patient. So let's go see her foot now. So prior to this surgery, she was getting absolutely 0 degrees range of motion in the first metatarsal phalangeal joint. Now, your foot, your toe, you couldn't move it at all before the surgery, right?
Oh, no.
So there was no movement in the toe before the surgery upwards. So what I'm going to show now, even with her foot loaded, I want you to look at the range of motion we now have. So there's a lot more range of motion than it was prior to the surgery. So this should take care of her pain. And the way we did this, we left the implant in place. We did the PRIV procedure here, and we did a oblique Aiken osteotomy and combined with a bony Kessel to pull the toe up. So now the only pain, she had a little bit of pain dorsally here, but her joint doesn't hurt anymore, so it's not having pain anymore. And so I want to show that to you and let you know that one of the keys with minimally invasive surgery, you can do these little things around fixation, how to take fixation out, or around implants. So it's a good technique to redo without having to go into large surgical corrections. The old way I would have treated this years ago before I joined the academy would have been to fuse her joint, or even possibly replace the implant. Those are big surgeries, and you have to go through a lot of scar tissue. This way we're able to minimize the scarring and be able to fix her foot through in the office under local anesthetic. Okay, just to finish this video up on how we corrected this implant issue that failed with a house limitus, I want to talk to the patient as well, and she can tell you give you some indication of how the traditional surgery fared as opposed to the minimally invasive surgery. Let's see our patient. Here is our patient. Let me ask you this. The traditional surgery you had years ago when they put the implant in and made the incision on top of your foot, how long did it take you to get over that surgery?
Oh God, it was months.
Right.
It was split open and just stayed there and just kept peeling all off. And
right.
I thought it was going to never get well.
Right. And so even though we had to redo her surgery through minimally invasive surgery, which always redos are normally worse than the first surgery, with this minimally invasive surgery, how would you compare your recovery with this?
A lot faster.
Good. Yeah.
First time I didn't even get one of those.
Right.
I only put the small shoe on, and I kept bumping that foot.
Right.
And I went back and he gave me another one, he gave me the same one.
Right.
He never put that on.
Right. What she's alluded to there, we did put her in a cam walker to keep our fixation in place. So actually with our minimally invasive surgery, we actually did more surgery. We did an osteotomy on the first metatarsal and actually put screw fixation there. And we did an osteotomy on the hallux. The original surgery, where there was no osteotomies performed, there was an implant and no osteotomy. So you would think that performing the osteotomy would give you a bigger recovery, but it doesn't. Minimally invasive surgery gives you a lot less soft tissue damage during the procedure, and that's why it's a quicker recovery for patients. I'm Dr. Peacock. This morning we're going to follow up on our patient that we performed a minimally invasive surgery to correct a failed implant. When she presented with us, she was unable to even move her toe at all. And this is 5 months status post. What we did was a osteotomy through and through on the metatarsal, which made a small incision, almost hard to see with minimally invasive, but it's right in this area here. And we went through and through at an angle, and what we did was did a Waterman completely through, so the cartilage was shift up dorsally. And we came to her toe over here, made a stab incision here, and basically here did a bony capsule, but we did this around the stem of the Hemi implant without taking the Hemi implant out of place. So with minimally invasive surgery, we can work around fixation sometimes. Now I'm going to let the patient move her toe. Move your toe right now. See, now she has movement in her toe. And if you look at the actual range of motion now, which she had 0 before the surgery, now she has more than adequate range of motion in her foot. And so we're now 5 months later. These osteotomies have healed, and she was having quite a bit of pain with her foot. So I want to show you her at this stage, and we'll talk to our patient here. Let me ask you this: now with your foot, are you happy with this procedure?
Yes, I don't have any pain.
No pain. So that's what we try to strive for, is to have no pain with this. And back when I was doing mostly traditional, I would have basically made a big incision here, taken out that Hemi implant, and either fuse this or replace it with a total joint. And that doesn't work all that well. That really is slightly debilitating for patients. Now we've been able to remain, keep her function of her toe intact and everything moving right, so she can walk as normal, and now pain-free. So we accomplished our goal through minimally invasive surgery. It's a great technique for working around other failed surgeries without having to remove fixation.